So I wanted to spend a moment discussing crisis care in this crisis care continuum. Many have been tracking conversations that we started early on, well before we thought we needed them, working broadly with a whole number of people in the state to talk through what is this continuum. Just to sort of level set and give you a little sense, we try to spend, and in normal times, our hospitals are delivering care in what we call the conventional care section of this chart. You'll see that the space is usually what we'd expect: single rooms with single beds, double rooms or group rooms with appropriate number of beds, ICUs with patients in one bay, emergency departments who aren't boarding and keeping patients who really need ICU care longer than normal, staff used in this sort of usual complement of staff that you'd expect in each unit, supplies that are readily available and that are available not just on the nursing floor or the medical ward, but also in the warehouses of each hospital, and that we're sort of at this usual level of care. Contingency care, which frankly most hospitals in California are operating today in contingency care. This is where you start to see space in the hospital that is used for other types of care. Here's an example: the post-op or the pre-op beds in certain hospitals are now being used to serve COVID patients or non-COVID patients to make sure that we have all the care spaces we need. Again, single occupancy rooms converted to double or even more occupancy rooms, staff who are working longer shifts in different staffing configurations with different levels of supervision, supplies, you're in this mode of trying to conserve them, adapt them, occasionally reusing supplies that you would otherwise dispose of, again, doing that safely, and then levels of care, functionally equivalent, but you may be delaying movement of patients between levels of care for some rate limiting steps such as staff or space. And then what we are spending so much of our time trying to avoid across the state, making sure that hospitals don't move past this contingency care area, avoiding this crisis care, where you're seeing space used not just in unusual ways, but that the space doesn't have all that it needs, that you're using cots instead of hospital beds, that units where you normally have all of your monitored patients on different important monitors to keep managing care, that they are in other parts of the hospital that they aren't usually found in. Staff are working significantly in different configurations, supplies, and I'm going to use the word here that I think it's an important one to emphasize, that in crisis care, you are in situations with occasionally you have to ration certain supplies, certain therapies, and even in a case where you may have to ration your staff, that there might be situations where certainly staff are stretched pretty thin and not every patient gets the same level of attention that we would hope they would in either conventional or contingency care situations. And then the level of care is in crisis. You may have to triage medical care, decide how you're going to use other scarce resources. Again, something that we need to plan for, be prepared around, but do everything in our power today to keep us from being in this situation across the state, not just within the region, but every single facility providing care to COVID patients. We're working hard to make sure we can keep them out of crisis care as long and as much as possible. Next slide, please. So what's our current situation here? Certainly with the current surge, many hospitals are being stretched to provide the care we want and expect in California. I think often of an analogy or a comparison to a rubber band that you do stretch, and you can certainly stretch many rubber bands pretty far, as we are stretching many of our hospitals pretty far. But we know that that stretch has a limit before it breaks, before we push them into a situation where they're making the kind of decisions about resources and staff that I just walked through. I do believe that hospitals are handling this surge as well as possible, and they're adapting their operations and space in very important, innovative ways to make sure we can do as much as we can on the campuses of the hospital. We learned early on through hours, weeks, months of planning for alternate care sites, pop-up medical facilities throughout our state, that the best option we have is to continue to work with the assets at the hospitals as long and as much as possible. That's where the pharmacies are, that's where the labs are, that's where the personnel are that can make care happen better, smarter, and more efficiently and in a higher quality way. So we continue to work to bring as much care at in those existing hospitals as possible. But we do have to acknowledge that we need to be prepared for the possibility that some hospitals will need to resort to crisis care, that in which, as I said, medical professionals have to make hard choices and allocate resources different than we usually do. Next slide, please. Hospitals and crisis care continuum. As these resources become more scarce and as hospitals are pushed to their limit, hospital crisis care guidelines planning and implementation become critical to ensure the best care possible is delivered to all Californians. This is what we've spent many, many months on, working with a number of partners, and Kim will be walking us through that in just a minute, but it's to emphasize that this care needs to be guided by ethics, equity, and in a transparent way. If individual hospitals in a county or region report implementing crisis care, that they've moved beyond contingency care, then other hospitals will be asked to share their resources and temporarily change their operations. This is something we've been having many, many discussions, late night discussions and conversations with hospital leaders, association leaders across impacted regions to make sure we are preparing for a hospital that maybe isn't as big as some of the ones we're used to, are in communities where there's a great disproportionate impact, that have had a hard time keeping their staff healthy and in the hospitals working, that we may need to call upon some bigger facilities to support smaller facilities, less impacted facilities to support the more impacted ones. We expect to do that with a great deal of planning, and to do it with haste when it needs to happen so that we can continue to save as many lives as possible. Next slide, please.